So, I was kind of thinking about splitting this up to talk for about, half the time on kind of some of the issues related to diagnostic challenges. And when we talk about liver cancer, there's multiple types of liver cancer, but for the most, by far, the most common type is hepatocellular cancer, or HCC, which you've been hearing a decent amount so far today. Um, and so the first thing we kind of have to ask ourselves when we're thinking about challenging issues related to diagnosis is who's actually at risk for liver cancer, right? So we always think about when we're thinking about, do we need to do any testing for certain patients? Who is at the highest risk? So who are going to get the most benefit out of trying to do screening? So basically, there's two main groups of people who are at risk for liver cancer. We have all the different causes of chronic liver disease, and we like to say that all roads lead to cirrhosis. So whether a patient has hepatitis B or hepatitis C or fatty liver disease or alcohol-associated liver disease, anytime those progress to cirrhosis, those patients are the ones who are at highest risk for liver cancer. Separately, kind of independent of cirrhosis, hepatitis B is a virus that is what we call hepatotrophic, and so it really just infects. It's in the bloodstream, but it goes straight to the liver, and then it is similar to other viruses. You may have heard of Epstein-Barr virus before, or HIV. These are all viruses that cause cancer. They cause mutations and can lead to cancer. And so hepatitis B, independent of cirrhosis, can also lead to liver cancer. And so when we think about these two groups of patients, these are the ones what we typically do screening on to look for liver cancer. Now, in the last 10, 15 years, we've also learned about something called the metabolic syndrome and what we used to call NAFLD, but now we call metabolic kind of associated liver disease. And we know that patients who have some of these risk factors, so obesity, diabetes, high cholesterol, high blood pressure, these are all independent risk factors for liver cancer. What that means is that if a patient has, say they have hepatitis B, well, if you have two patients in front of you, both with hepatitis B, the one who has diabetes is more likely to get liver cancer. And so we do think about these issues as well in the U.S. in particular. These are, kind of a growing population of patients. And so we in clinic will think a lot about trying to modify some of these risk factors, right? Weight loss, exercise, trying to get better control of cholesterol or diabetes. So to try to improve outcomes, and including related to liver cancer. So for those two groups of patients, first, for most patients with cirrhosis, as well as many patients with chronic hepatitis B, we typically perform surveillance, which is applying a screening test at regular intervals in those patients who are at risk for liver cancer. And so the most commonly used surveillance in clinical practice is doing an ultrasound with a tumor marker. You may have heard of alpha-fetoprotein, or AFP, typically every 6 months. Now, AFP is an interesting biomarker. And when we think of biomarkers, we think about, usually blood-based tools. Probably the most used one in cancer, is the PSA, which is a tool for prostate cancer, but there's multiple similar tumor markers for other cancer types. And so alpha-fetoprotein is by far the liver cancer biomarker with the most data for it. The problem is it's not a great screening test. It's by far from perfect. If you have a screening test, what you really want is for someone who has the disease, like in this case, liver cancer, to have an abnormal alpha-fetoprotein. But when you look at the test characteristics of AFP, it turns out that about 40% of patients with liver cancer actually have a normal AFP. So the test is not all that sensitive. So really, we shouldn't be using it on its own. That's why we add ultrasound. On the other hand, it's also not something called specific, meaning that just because you have an abnormal AFP doesn't necessarily mean you have liver cancer. So for both these reasons, we take into account a patient's AFP and the trend, but it's not perfect. But we do know the higher the AFP, the more likely the diagnosis is. And every lab is a little different, but we tend to like a cutoff of around 16 to 20 that performs the best when you look at these test characteristics. So a lot of times we'll have patients who say, hey, my AFP is 8 and it's flagged as abnormal, and they're really scared. But if it's been 8 for years, or or the fact that it's, just a little bit over the upper kind of limit of normal for the test, it may not be, indicative of a new diagnosis of liver cancer. That being said, so as a screening test, it's only so-so. As a prognostic marker, it's awesome. AFP predicts overall mortality in HCC. It predicts prognosis after resection and predicts prognosis after transplant, except all the things a patient might ask you about. AFP can be helpful once a diagnosis of HCC has been made. So when we think about surveillance, and again, the most common is ultrasound and AFP every 6 months, we really have to try to figure out the benefits and the harms for individual patients to try to sort out if our patient should be going through surveillance. So, when we think about surveillance, we often think of just about benefits, right? So there is great data that doing ultrasound and alpha-fetoprotein every 6 months leads to earlier liver cancer detection. So at an earlier stage where it's more treatable. Including patients are more likely to be able to receive curative treatments. It also leads to improved survival. And so that's great, obviously, but there are some harms, right? So patients can undergo maybe unnecessary biopsies because of surveillance. They might have psychological distress, and there's also some financial burden. So we do want to really think about some of these risks, benefits, and harms when we're thinking about an individual patient. So, while most patients with cirrhosis or hepatitis B should undergo surveillance, probably there's some patients who may be so sick from something else, like severe heart disease or lung disease, that it may not make sense to offer a patient surveillance. For example, we've had many patients who come to clinic who you ask them, hey, if you have a diagnosis of liver cancer, would you want to be treated for it? And they actually say no, and that's okay, but it's important to ask some of these questions because it may inform our decisions to perform surveillance. So goals of care, age, comorbidities, all these things influence these decisions. But for the most part, patients with cirrhosis and hepatitis B are recommended to undergo surveillance with ultrasound and AFP every 6 months. Now, if we do an ultrasound and it's positive, meaning there's a lesion, or someone's alpha-fetoprotein is rising, then we move on to cross-sectional imaging. We typically will get either a CT scan with contrast or an MRI with contrast of the abdomen. And what we're looking for is specific characteristics of liver lesions that point us the direction of a liver cancer, in this case, a hepatocellular carcinoma. So we know that that HCCs are typically fed by something called the hepatic artery. So in the arterial phase of contrast, they look bright, and then later on they look dark. So your providers may use words like enhancing lesion or washout, and that's what those reflect. And then sometimes the lesions can actually have a capsule around it, kind of like a ring around it, not this yellow ring, which I drew, but this kind of ring around the lesion that may also make the diagnosis more likely. And so the radiologists put all those things together, the size, the washout, all the enhancement, and they come up with a scoring system, this LIRAD scoring system that you'll see if you ever review any of your own, CTs or MRIs, that if there's a liver lesion, then they'll assign it a LIRADS designation from 1 to 5, where 1 is definitely benign, 5 is definitely liver cancer, and there's other options. And those actually are quite accurate in terms of, leading towards a diagnosis, where LIRADS 5, sorry, it kind of didn't come out great. LIRADS 5 lesions, the vast majority are liver cancer, and 49 out of every 50 lesions are definitely malignant. And so this is where we kind of basically cinch the diagnosis. There's also something called LIRADS M, where M stands for malignant. And so the vast majority are malignant lesions, but most are actually not liver cancer. So this might be where there might be a bile duct cancer or a metastatic lesion or something like that. So we get together at UCSF, we do this twice a week. There's good data that tumor boards improve outcomes for patients with liver cancer. And so we have a twice weekly liver tumor board where hepatologists, surgeons, interventional radiologists, abdominal radiologists, oncologists, radiation oncologists all get together and view all of our patients' imaging, which have suspicious liver lesions, to confirm the diagnosis and staging, and then determine treatment strategies. A lot of people ask, what about biopsy? And so, sorry, I keep doing that. Liver cancer is one of the most interesting cancers because we actually don't often biopsy lesions. Sometimes we will, but it's not actually a pathologic diagnosis. It's actually a radiologic diagnosis. If a patient has cirrhosis or hepatitis B and they have a LIRADS-5 liver lesion, then that we kind of make the diagnosis. Biopsies are okay though every once in a while you'll see false negative biopsies that could lead to delay. There is a rare risk of tumor seeding along the needle biopsy tract, but that's not really a big risk we care too much about. It's gotten lower and lower risk over time. So really, we just biopsy those LIRADS-M lesions I mentioned earlier, or if a patient has a lesion that looks like liver cancer, but you say, "Gosh, I don't actually see any risk factors for liver cancer," then we'll often biopsy those lesions as well. And so once our radiologists give us these LIRADS designations, that really helps inform what the next steps are. We're not going to go through this for a lot of reasons, but we then in tumor board talk about these things. We'll just pick one, for example. Let's just go through LIRADS-3, an intermediate probability of liver cancer. So we'll get together in tumor board and we'll say, okay, what should we do? So probably what we would do is say, okay, we're worried, but we haven't come close to making a diagnosis. Let's repeat, or they got a CT, let's do an MRI in a few months or something like that. So for each of these designations, we then come up with a tailored plan that may or may not include biopsy. Now, once we actually have a diagnosis of HCC in the last few minutes, I just wanted to briefly comment. By no means should anyone look at all these words and think that it needs to be memorized. But there's a lot of different staging classifications that are out there to think about how we manage liver cancer. And just like every other cancer, we do staging. Is it very early stage? Is it advanced stage? And we make those considerations. This is the Barcelona liver cancer staging. There's others, but this is the most commonly used in research and clinical practice. We'll take into account how much tumor they have, how big and how many lesions. Is it just inside the liver, or is it spread outside the liver? That would be advanced stage. But again, remember, most patients with liver cancer have cirrhosis, and so we can't just take into account the tumor. We have to take into account the underlying liver function, because we don't want to be applying treatments that they're not going to tolerate. And so we take into account liver function, physical status, and a lot of their labs to really put them in these different staging, which can help us then determine the first line treatment options. So let's just pick one, for example. Let's pick transplant. So transplant is typically done for patients with relatively early stage cancer who don't have any, we want to think about contraindications to transplant. And we want to think about their tumor markers, but we wouldn't be doing transplant, for example, with someone who has, advanced stage cancer. So this is a way that we can kind of try to tailor our therapies based on all these important variables. So this is what we do in tumor board and in clinic to really help us with these prognostic issues, because depending on your stage and your treatment, there's pretty clear expected survival. So we want patients to be on the left side of this graph with the earlier stages where they have better expected survival. As you move to the right, where you have more tumor or worse liver function or tumor spread, now your survival is getting worse and worse. Such that, for example, with transplant, we'll talk about this briefly, but expected survival after transplant is like 85% at 5 years, versus with advanced stage, median survival is only like 2 years. So you're really, if we make the diagnosis, we're really hoping for patients' sake that we have a lot of these curative treatment options available. The curative option that we try to do first, if possible, is resection. That's where you cut out the tumor. The problem is that, again, most patients, especially in the US, have cirrhosis. And, if you have cirrhosis and you cut out part of this liver, you have a pretty significant chance of liver failure. So we have to take into account how sick patients are, their labs, when determining if their liver function, when determining if they can undergo resection, along with how many lesions they have and the size. And if they're not a resection candidate, then we think about transplant. So transplant, we have pretty strict criteria in the United States in terms of how much tumor they're allowed to have. Again, you can't have spread outside the liver or into the big veins. But this is national criteria, so patients have to really meet these criteria or be downstage. Their tumor has to shrink with treatments to get into this criteria. But if they can do that, then they have really good expected outcomes after transplant, 80 to 85% survival after 5 years, and relatively low rates of tumor recurrence, because not only are you're taking out the whole liver, so you're taking out the cancer in the cirrhosis as well. There's a lot of different ways to treat liver cancer. We're not going to go into these, but these are some of the different types of treatments you might hear about when you're discussing with your hepatologist or oncologist. But there's some are done by interventional radiology, some are done by radiation oncology. But even though those tumor criteria are pretty restrictive, we do have the ability to shrink tumors with those treatments I just mentioned to try to get patients to within conventional transplant criteria. So this would be downstaging a patient with like a 7-centimeter tumor. Now it's less than 5 centimeters. We can do another treatment and try to make it all look dead. And this really then allows this patient to be able to be listed for liver transplant. So that's a process called tumor downstaging. And then in the last minute, I just want to mention that once a patient has advanced stage, so now the tumor is spread into the like the portal vein, for example, or spread outside the liver, then we're really limited to just systemic treatments. So we wouldn't really pursue any of these other surgical or other treatments. We typically think about systemic therapies. And the one good thing about this is that, 7 years ago, we only had one option. We just had something called sorafenib, which is something called a tyrosine kinase inhibitor. In the last 5 years, we've had an explosion of treatment options. We have multiple first-line options. We just heard about immunotherapy in the last session, but there's also multiple different treatment options. One of them is called atezolizumab and bevacizumab, for example. We're not going to go through any of this data, but it basically showed that this combination of something called a VEGF inhibitor with immunotherapy improved outcomes compared to sorafenib, and so that's one of the new first-line options. But we're really in the last few years seeing an explosion of better options to really improve outcomes for patients with more advanced disease as well. So I think that's the end of my time. It's 2 minutes over 9:20, but happy to answer any questions. Thank you.
Thank you, Dr. Mehta. We appreciate your presentation. Looks like we've got a couple of questions here. The first is, what are the chief symptoms and side effects of hepatic portal vein, I think invasion, maybe they meant?
Yeah, it's a really good question. So basically, there's often not symptoms related to any liver cancer, actually. You have to be pretty advanced. That's why surveillance is so important, because the vast majority of patients with liver cancer have no symptoms. And so if they do have symptoms, it's almost certainly very late in their disease presentation. But the second part of that question that you wrote is, do you observe any varices? And yes, because if a patient has portal vein invasion, they may have higher pressures in the portal vein because of that restricted tumor flow. So you may be more likely to have varices. The other key point here is, let me just show you my screen again, is this trial, this atezo-bev. The bev is actually something called a VEGF inhibitor, a vascular inhibitor, and so it actually can increase the risk of bleeding. And so for both the two reasons, the question from Roger about the portal vein invasion, as well as the side effects of this medicine, we recommend an upper endoscopy before starting this specific agent to make sure patients don't have really high bleeding risk.
Absolutely. The next question is, what about the incidence of HCC in patients with non-cirrhotic livers?
Yeah, it's a really good question. So it really varies. The main etiology of liver disease that influences is hepatitis B. So hepatitis B, independent of cirrhosis, can have a pretty significant risk of liver cancer. And those risk factors would be how old the patient is. Do they have a family history of liver cancer? Do they have active inflammation of their hepatitis B? So these are the things we take into account when we're trying to decide if a patient without cirrhosis with hepatitis B needs to get surveillance. Other than that, we know that the risk of liver cancer does go up slightly with more scarring. So we think of fibrosis on the scale of 0 to 4, where 0 is no scar and 4 cirrhosis. Well, so it turns out that if you're on the 3, something we call bridging fibrosis, those patients do have a slightly increased risk of liver cancer, whether that is inflammation from hepatitis C or alcohol or what have you. But it doesn't yet reach the threshold that our main governing body, AASLD, recommends screening for. the European body does, but we don't. So we only screen patients with cirrhosis, but the EASL guidelines suggest potentially screening patients with F3 or almost cirrhosis.
Right. The next question is on the prognosis slide. What qualifies as end-stage liver function?
Yeah, so that's a good one. So when we think about prognosis, the two types of function we think about is an individual's physical status. So that's very commonly used in the cancer, in all cancer types. What is their physical status? You may have heard of something called ECOG, which is a Eastern Cooperative way to designate functional status. Is a patient able to work? Are they in bed all the time? Or somewhere in between? So that is important, and that's what that PS or physical status refers to. And then the other one is liver function. What is their bilirubin? What's their INR? What's their MELD score? Because we know that if a patient has poor liver function, they may not be able to tolerate certain therapies. So it's a combination of liver function and physical function.
Question 4, is it true that currently with radioembolization and chemoembolization that this treatment cannot target the tumors and it is we basically only hope that it works?
I see. Yeah, no, it actually turns out let me see if I have any. Okay. Yeah, it turns out that those types of treatments, they're both done by interventional radiology and they both go through the hepatic artery. And they actually do specifically target the tumor. So they can get in pretty selective, and then they can actually do something called an angiogram, and they can actually see where the tumors light up and then direct the chemo or the radiation directly into the tumor. So they actually can be quite targeted. It's actually the systemic therapy that's non-targeted. Those are through infusions every 3 weeks or pills. So that's like the whole body. But the interventional radiology treatments can be quite targeted.
Right. And then obviously the hope is that all of it works, right?
Yeah, exactly.
That's always the hope. Question 5, in terms of surveillance, how do you counsel patients with metabolic risk factors?
Yeah, that's a hard one. We don't, with surveillance in particular, we don't include any one particular metabolic risk factor to determine if we do or don't do surveillance. But as a whole, we do. And when we're in clinic, and it's not just part of the cancer discussions we have with patients, but it's really in the progression of their liver disease and kind of their overall metabolic health. We talk a lot about, so in terms of exercise, we typically recommend about 150 minutes a week of kind of a combination of aerobic and anaerobic exercise. We like lifting weights. We try to do a combination of both aerobic and anaerobic. Obviously, if a patient has cirrhosis and poor liver function, they may not be able to do that. So but we still talk to them about specific exercises that they can do. We have most of our patients see a nutritionist as part of their evaluation. Our goal for A1C, we're really trying to get under 7% if possible. And then statins are certainly safe in patients with chronic liver disease. And so we do often recommend them. And then obviously the new thing on the block, all this about GLP-1, these kind of weight loss and diabetes medications is we're quite in favor of them, though we still are waiting for kind of longer term data to see if they reduce cancer risk or reduce cirrhosis risk, et cetera.
Okay. Do patients with a cirrhotic nodule get diagnosed as being on any level on the LIRAD scale? That's one part of the question. And then the second is this shared with the patient?
Yeah. So, yes, we any nodule gets assigned to LIRADS, and then that is put on the MRI or CT report. And then, like at UCSF, for example, reports after either immediately or after 5 days will immediately be shared with the patient through something called like MyChart or their patient portal. But we also discuss what that means, and it can be quite it can be a lot of stress for patients to see this, and because they see a lesion. So the nice thing is now we can assign numbers and have a discussion about what to do next. And that's what we do in Tumor Board. And that's what we do based on these. So yes, we do share that with patients. If a patient has, 3 lesions in the liver, they might have 3 different LIRADS designation, 3, 4, 5, or all 5, so we talk about these things and we really kind of plan our next steps accordingly.
Right. Depending on where it lies on the LIRAD scale, it sort of drives the further screening and
right. And treatment. Yeah, that's right.
Okay, I think that completes our questions. Thank
Great.
you.
Yeah, thanks for having me. I appreciate it. This was a lot of fun.